I'm just going to introduce our next speaker, Dr. David Feifel, president of Kadima Neuropsychiatry Institute in La Jolla, I hope I say this correctly, and professor emeritus of psychiatry at the University of California, San Diego. He's going to present some data on R-Ketamine for treatment-resistant depression. Thank you.
Thanks, great. Well, it's wonderful to be here. I was here in 2018. It was a much smaller group, more intimate, I would say. But it's great to come back, and I haven't been in the interim, and just to see how much we've progressed. But also, I think it's kind of interesting to see how much we've not progressed. I mean, we were still dealing with a lot of the same questions. And then I was thinking about the first presentation this morning about sort of going back to Galen and the theories of depression and trying to figure out and think of how many hundreds of years have passed, and have we really made that much? Are questions really that much fundamentally different? You would think with all the technology we have, we can peer into the brain, we can look into the genes, and yet here we are. We're still trying to figure out, how this magical process of emotions take place. I want to tell you a quick story. In around 2007, 2008. Oh.
It's quite challenging to hear in the back.
Oh, you know what? I wonder if my little speaker's on. It's okay. Okay, I'll talk louder. My wife keeps telling me to not talk as loud, so it's kind of counterintuitive for me. But around 2007, I'm a very demoralized academic psychiatrist, because I went into psychiatry thinking that I'm going to be part of the golden age of psychiatry. All these great advances in neuroscience are taking place, and they're going to translate into these amazing new treatments, just like in the 60s, when the heart surgeons were able to transplant hearts, and it was what a great thing to be able to be part of that era. But I'm a faculty member at UCSD for maybe 10, 12 years now. And I'm thinking, I might have missed the boat, because I'm still prescribing the same kind of stuff that I prescribed, that my mentors were prescribing when they were medical students. Essentially, I mean, they had nice fancier names and maybe less side effects, but essentially I'm still doing the same kind of things. And I have an animal lab that's NIH funded, and we're looking at new targets, and but it's very frustrating, because I just feel like maybe I'm going to miss the boat, and my residents are going to be the lucky ones who are going to ride this revolution wave. And there's a couple of things that are happening. TMS gets approved, and I've been watching this for a long, long time, so I convinced my chairman that this is not some voodoo kind of thing, so we get a TMS machine. And then I keep looking at these two papers, one in 2000 by Berman and another in 2006 by Zarate, and I'm like really skeptical, because it just doesn't seem like it's possible to cure depression or have these amazing improvements in just within a single infusion. It just doesn't make sense. It's so intractable. But I said, you know what? We've got nothing else, and if only half the effects are what they are in this paper, that would be amazing. So I went to UCSD's Pharmacy and Therapeutics Committee almost to be able to prove myself that this isn't a real effect. And first they said, do you want to do what? You want to give what to depressed patients? I want to give ketamine. So it took about 8 or 9 months of convincing. And eventually we got the permission, and we had to write a protocol, blah, 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 academic medicine. And we did our first ketamine infusion October 2008. And I remember it, because we were all so excited. I read these two papers, and it was like 70% response rates. First patient doesn't get a response. 40.5 milligrams per kilograms IV, no response. Second patient, no response. Third patient, no response. I said, come on, this is such BS. I mean, what are the statistical chances that I got 0 out of 3, given the high rates of success in these two papers? And I'm about to give up, and I start reading a little bit more about ketamine. And one of the things that I didn't mention was when I went to the P&T committee, they said, okay, you can do this, but you have to do it in the PACU. So the PACU is sort of like a post-operative recovery place. It's where people after ECT go, after surgery. It's very chaotic and noisy and stressful. And they said anesthesiologists have to administer it. So it's fine. So our patients came into this place. It was incredibly, it's a overly stimulating place. And they're sort of in this little, on a gurney separated by curtains. And an anesthesiology resident kind of opens the curtains up and grabs the chart and says, okay, what are we doing? What procedure is this? And we're like, no, there's no procedure. It's just a ketamine infusion. They go, what do you mean? Like, what's ketamine for what? It's just a ketamine infusion. We're hoping to have a therapeutic effect. And they're like so grumpy. It's like, I'm busy. What are you doing this for? It's like, I've got patients that are going to the OR or whatever. Anyway, so then I realized how really unpleasant that must have been. And I never thought of it that way because I had gone into the field as a neuroscientist thinking about the brain, and it was incredibly non-conducive, let's say, to a drug that I was starting to learn may have, and the context may have an impact. So I decided, okay, before I quit, I want to try in a different setting. I went back to the P&T committee. I said, can you move me to a different setting? They were grumpy about it, but they finally moved me to an outpatient setting, the Moores Cancer Center, which actually, despite the name, was actually a lot more pleasant. People had kind of like semi-private rooms, and there was, we had two spots, and there was one room had a window, and there was a tree outside of it, and another room didn't have a window. But suffice to say, I'll save that story for another day, but suffice to say, everything changed. And I started getting these most incredible results. And I didn't realize at the time, but that was the first ketamine infusion program anywhere in the world, 2008, as far as I know. I say this because I'm really happy that this conference was initiated by Rupert, who I think he would probably describe himself as primarily a clinician. And I know that I've got some clinician colleagues in here. And I think if we're going to make progress in this field, we can't only be looking at rat brains. And I'm a recovering animal model. That was my NIH lab was all doing animal models of schizophrenia. So I learned so much from those 3 patients, more than I could have imagined doing, in years of research on animals or even randomized controlled trials, I think. And I'll tell you one last quick story. Ed Domino, if you all may know, was the person who was the first one to put ketamine. I think it was called C1. Does anyone know the number C1987 or something? Park Davis. He was the first one to put it in humans because Park Davis asked him to test it as an anesthetic, and he found it was an amazing anesthetic, and he coined the term dissociative anesthetic. Anyway, I got the pleasure to meet him. Dennis Charney introduced me to him when I was giving a ketamine poster at ACMP. And he's, in his twilight years, as we might say euphemistically, and he's incredible. And he says to me, David, I could have discovered the antidepressant effects of, and he's a psychopharmacologist, so he was testing this as an anesthetic, and he wrote the early papers in the 60s as a wonderful anesthetic. So it's, not really a psychiatrist or somebody who dealt with mental. I could have discovered the antidepressant effects 40 years ago. I said, what do you mean? He goes, well, they were sending me, because I was the ketamine expert, and I ran the psychopharmacology clinic at Loyola. They would send me all these patients who were starting to abuse ketamine because it was starting to be diverted, and I would interview them, and they would and a lot of them would tell me that they're doing this because of their depression, and I thought they're just saying that they're just drug abusers. And he said, I remember one lady, and she told me that she takes it for her ketamine. She self-administers. She gets it. Somebody steals. Somebody I guess diverts it from veterinary clinics. I don't know exactly how, but she says. She said, I said to her, ma'am, you have to go to a psychiatrist and get on prescribed drugs. And she says, you don't understand. I've been on so many drugs, none of them do anything like ketamine does. It's the only thing that's ever improved my depression. And he says, I just wrote her off as just another drug addict who was trying to make excuses. And he turns to me and he says, David, the moral of the story is always listen to your patients. So with that, I want to dive into a little bit of a digression. Sorry, I hadn't planned on telling those stories, but when Jonathan was talking about, kind of made me inspired me. These are my acknowledgments. I'm not going to go through everybody here, but everybody except for Srini Rao either works for or had worked for Perception Neuroscience. Srini is actually the CEO of the parent company for Perception, that is Atai Life Sciences. My disclosures, I don't work for Perception Neuroscience, but I was an early advisor. Jonathan Sorkin. Hi. I didn't even notice you. I'm passing. Do you remember the days you came to Kadima and you were asking me all about intramuscular injections, subcutaneous injections?
I remember well.
That's right. So those were the early days. We're trying to figure out what's the best. But I was involved in some of the early advisory boards. I remember one that was at ACMP, and I was a site PI contracted for the phase 2 studies. I'm not going to tell you about what R-Ketamine is. You all know what it is. The important thing is that R-Ketamine has about a 4 to 5-fold lower affinity for the NMDA receptor than S-ketamine. And you know that S-ketamine has now been developed as a FDA-approved drug. And I can tell you in my clinic, we're probably at about 30% of all treatments are now Spravato, which is the brand name for it, or Spravato-based. And we have some ways of augmenting it, but I don't want to get into that. So what's the rationale for wanting to develop R-Ketamine? Boy, what's the term? I feel like I'm bringing coals to Newcastle with Jonathan sitting right here in front of me. It's a little nerve-wracking. But what's the rationale for developing R-Ketamine? Well, the idea is that the NMDA receptor has been pretty well established as sort of the mediating factor for what we call side effects. I put side effects in quotation marks because my patients would not call them side effects. They're upset when they don't get the side effects because they feel that they're not going to get a good antidepressant effect. So it's interesting how we kind of label certain things, but the dissociative effects, the psychosis effects, the hallucinogenic effects are all thought to be mediated by the NMDA receptor. But there's a lot of good evidence, mostly preclinical, that the antidepressant effects, and we've been hearing about this today, the antidepressant effects may not be mediated by the NMDA, or not fully mediated by the NMDA receptor, but through other mechanisms for which R-Ketamine actually is at least as active or maybe even more active than S-ketamine. So in essence, we have a situation, in theory, where you have an isomer that has less activity on the mechanism that produces the side effects, and maybe, but maintains or maybe have superior activity at the mechanisms where the antidepressant effects occur. So, in theory, this is like a good candidate to develop as a improved upon racemic ketamine. I'm not going to spend too much time on this because I ended up telling those stories I wasn't planning on telling. But I can tell you that most of the evidence comes from preclinical models. You know, things like hyperlocomotion, PPI prepulse inhibition deficits, which are supposed to be sort of proxies for psychosis, are all much more potent with S-ketamine, almost absent when you give R-Ketamine in animals. On the other hand, things like social defeat, learned helplessness, and for swim test, as well as a lot of the molecular things that we associate with antidepressants, like BDNF, stimulation of BDNF and synaptogenesis, are actually produced in a more potently and for a longer duration with R-Ketamine than they are with S-Ketamine. And so and then, of course, there's a 2016 paper that came out in Nature by Zanos with Carlos Zarati's group that showed that actually maybe one of the key metabolites, in fact, the R enantiomer, one of the key metabolites, hydroxynorketamine, might be the smoking gun for most of the antidepressant effects, and that seemed like it was via the AMPA glutamate receptor, not the ketamine receptor. So a lot of evidence to suggest that R might be superior. And then there were 2 studies out of Brazil, small studies, open label, less than 10 people. One in treatment-resistant depression, one in bipolar depression that gave IV infusions of R-Ketamine and got really good effects, with very, very minimal side effects. Now, before I'm going to tell you about the studies that I'm going to tell you about, and I don't know if this study I'm going to tell you about, which is a follow-up to in the Brazilian group of a pilot study, a crossover study. I don't know if it wasn't published till 2023. That was after the phase 2 perception neuroscience study was already well planned. So I don't know if this was on their radar or not. But anyway, the Brazilian groups decided to follow up the promising work with R-Ketamine with a double-blind randomized crossover study, small, 10 people, getting a placebo, getting saline and ketamine in counterbalanced randomized fashion. And they were looking for changes in the MADRS, and this is what they got. This is the full crossover with both groups. But because statistically they found, I don't think this is working, or I'm not doing right. But because they found that there was a carryover effect, they just focused on the first period. So it ended up being a parallel design study with N of 5, but there was no real differences. But you can say 5 patients. I mean, was that really a test of R-Ketamine, given all the promising preclinical modeling that shows that it had advantages, and even those 2 open-label studies. On the other hand, in terms of side effects, and I think this was 0.5 milligrams per kilogram IV, so the classic dose that you give for racemic. On the other hand, the low side effect profile was validated very nicely. There was negligible dissociation, negligible blood pressure elevation, so that part was validated anyway. So this brings me to the meat and potatoes, so to speak, of what I want to tell you about, and that is the program to develop a PCN 101, which essentially is R-Ketamine. It's the startup Perception Neuroscience. Their R-Ketamine candidate, and there's been a number of studies that's been done by the company, including a phase 1, relatively large phase 1 study. The phase 2A study, which I'm gonna focus on, looking at 2 doses of R-Ketamine versus placebo, and bioavailability phase 1 study, bridging IV to sub-Q. The idea, I think, the idea that Perception Neuroscience had was to develop this, but it's also hopefully develop it based on its low side effect profile as a home treatment, subcutaneous home treatment. I'm not going to present the last study because for lack of time, but the phase 1 study was a dose escalating study, 6 cohorts. They did doses that ranged from 5 milligrams up to 150 milligrams. And their interest was really to look at, this was an IV, a 40-minute infusion. The idea was to look at the PK, but also the safety and tolerability, using the usual suspects, the CADs and the BPRS, blood pressure, things like that. And this is the results. Basically very nearly linear pharmacokinetics, which is always nice when you're trying to develop a drug. more importantly, here are just some of the results. And I know some of these data points aren't very visible, so I apologize for that. But looking at overall, there were pretty low level of side effects, low level of dissociation. Only doses really above 60 milligrams showed transient, moderate dissociation. 30 milligrams, almost none. 60 milligrams, just on the borderline, I think is what you might say. Same thing for the BPRS. This is less than you would expect from racemic ketamine, and again, kind of dose dependent. But even at the highest dose, wasn't terrible. And blood pressure, very transient systolic increases, less than 20 milligrams during the infusion, rapidly returning to normal after the infusions, even less with diastolic. So pretty safe. Safety profile looked really good. And so the conclusion was that that doses of PCN-101 up to 150 milligrams were generally safe and well tolerated. There were no serious treatment-emergent side effects. All were mild, except for one was moderate, but which was vertigo, and it resolved. And the most common treatment-emergent adverse events were headaches, dizziness, fatigue, and nausea. And as I said, even at the highest doses, it was very short-lived. And so based on all of this, they decided that they would go forward with the 30 and 60 milligram doses for the phase 2 study. The phase 2 study, the goal was to assess safety and efficacy of those two doses. And there were 20 sites, I'm told, in Europe, Germany, Poland, Italy, and the US. It was a planned N of 93, 31 subjects in each of the cohorts. 40-minute infusion, again, IV. And this is a schematic of the design. Now, importantly, when I looked at this protocol, the first thing that I saw that was kind of strange, and the US sites were actually added later than the European sites, was that what happens is the patients get admitted the night before they get dosed. So in our case, since we're not a licensed hospital, they just basically are hanging out overnight at our clinic with a staff member there. So and we do a lot of psychedelic studies with psilocybin and LSD. So we have rooms that are pretty comfortable, like the kind of hotel rooms that you can very, very comfortably stay overnight in suite bathrooms. So they were admitted the night before, and the next morning they got their 40-minute infusion of either placebo or one of the two doses. And then they're monitored pretty much for 6 hours, and then nothing happens, and they're hanging around pretty much till the next morning. Another overnight stay until, that was my response to this. Overnight stay until there's a couple of final assessments, and then they're sent home. And my first question was to Maju Matthews, who was the chief medical officer. Was like, why on earth are we doing this? This can't possibly be like FDA mandated, because we do LSD studies where people are there for like 12 hours and then we send them home afterwards. So I'm not sure exactly why, but at that point it was not possible to change the protocol, because it had already been recruiting in Europe. But I think that's something that is kind of anomalous in the world of these kinds of clinical trials. So I just wanted to point out, so basically, and then they were followed up outpatient for 15 days. The patients were 18 to 65 years old. They had to be on an stable antidepressant. They had to have a certain degree of symptom severity, HAM-D greater than 18. And they couldn't have had more than 8 ketamine treatments in their life. There was a primary endpoint, was the MADRS change, but there was a lot of secondary endpoints, lots of safety and tolerability, the usual things that you look at. Just a schematic showing, how things were. O2 sats were measured continually. There were EKGs done, during the infusion, and blood pressure pretty frequently. There was the CADs and the BPRS were done right after the 40-minute infusion, and then again at 2 hours, 4 hours, 6 hours. Okay, so 93 patients, average age 45 years old, 60% female. You can see the distribution. Almost 3/4 of the subjects were enrolled in Europe, and they had a pretty high MADRS score. So these patients were pretty severe, nearly 30 MADRS. And then these are the results. So you can see that there was definitely a very robust, rapid reduction, and 24 hours was the main endpoint, rapid reduction in the MADRS with both doses, with the 60 milligram being a little bit greater of magnitude, but you can see that there was also a very robust reduction with placebo. So in the end, at the key endpoint, the difference of 1.6 on the MADRS was not statistically significant, nor was it at any other time points. Now it's interesting because in their analysis, they found that there were regional differences, and that if they looked only at the U.S. sites, they had a little bit more of a signal, especially in the sustained group of people who improved and responded. So that at day 15, the 60 milligram, and sorry, because I think they reversed the color scheme here. So, oops. So that is placebo in orange, and 60 milligrams in blue. And so you can see that at 15 days, there actually is a statistically significant separation in an exploratory way. This was also reflected in sustained responders. So at 24 hours, there wasn't much of a difference in the percentage of people who were responders. But those that maintained their response for 15 days seemed like there was a signal. There were, 1/3 of the 60 milligram group were sustained responders, more than double in the placebo or the low dose group. So 62.5% of those who were responders at 24 hours were also responders at 15 days in the high dose, but it was in the 20s for the placebo and the lower dose. I feel like this is like an episode of Mad Men, and I've got my scotch, Anyway, here are the side effects. They are, I'll save you the time. There's not much going on even with the high dose. So the conclusions were that the primary endpoint, unfortunately, was not met. It was I think a lot of people were kind of surprised and disappointed. I'm sure there were there was a non-significant but consistent improvement in the MADRS across all time points in the 60 milligrams compared to the placebo. There was reflected in responders, and also I didn't show you the remitters, but it was also in the remitters. And it was a very high placebo response rate, which obviously may have played a role. But there was also regional differences, which may have played a role. And that when you looked at the U.S. sites, there was a more auspicious signature, especially later on, when you might expect a high placebo effect to start to wane, and any true bioactive effect to start to dissipate less so. So I think there's a lot to be learned here. We know that we definitely, this once again confirmed that R-Ketamine has much lower adverse events profile, less psychomimetic, if you consider that to be a good thing or a bad thing, but it is consistent with the animal models. And What are the possible explanations? I don't know. I mean, I don't think, I think that's open for speculation. First, I guess the big question is this a failed study or is this a negative study? Of course, there was no active comparator to serve as assay sensitivity to show whether the study had the capability of showing a positive response from a known drug like R-Ketamine might have been a good example. There was a very high placebo response rate, but there have been studies, clinical trials with higher response rates that showed separation. I think the S-ketamine studies are an example of that, and I even think back to the I guess it was called Repastinol, also had a very, in their phase 2, had a very high placebo, even higher, but still separated and showed statistical significance. Was the design part of the problem? The overnight stays, did that contribute to the high placebo effect? What about the regional differences? I mean, that's a little peculiar to have such differences. So there was a lot of issues. What does it say about animal models? Are they? I mean, there's the signal is so clear in animal models that R-Ketamine is efficacious. But in my opinion, and sorry to take a bit of a different stance on the predictive value of animal models, I don't think they're very good at all. If you look at all the failed, all the studies that are positive and that don't end up being positive in humans, if you go back and if you take drugs that are known antidepressants and test them in animal models, you do get a high rate of positive results. Also, I mean, it raises the question: is this a wrong-headed thinking about dissociation? And I don't even like the word dissociation because it limits what I mean. We do almost 4,000 ketamine treatments a year, and I mean, the patients will say it's all about what they feel and what they experience. So, are we going down? Is this a right approach to think of dissociation, something we can tease apart and still get efficacy? I have to say that so far the theory is not borne out, because I can't think of any drug that has this sort of ketamine-like rapid antidepressant effects without it. I go back to Repastinol, or was it Glix 13? I think it was the original name, which was going to be the myth buster that you have to have these experiences, and that failed. So I guess it'll be something for us to maybe conclude at ketamine and related compounds 2040. Maybe we'll have the final answer. Anyway, thank you very much for tolerating me.
All right, it seems